Great. So welcome everyone. It's noon, and this is our regular What's New talk series for our fellows in the Addiction Fellowship. And so today you'll hear about what's new in addiction medicine or nursing with Lukas Hestvik, who is one of our addiction nurse practitioner fellows this cohort year. And Lukas will be presenting on gabapentin and uh, an interesting evaluation of the literature and evidence and some suggestions about how this might impact practice. So I'll briefly note that I'm here in Nelson in the Kootenays on the traditional and unceded territories of the Ktunaxa and Sinixt peoples. And I'll ask everybody else to take a moment to acknowledge the land that you are on. And briefly, Lukas's bio. So Lukas is currently an addiction nurse practitioner fellow with the BC Centre on Substance Use and an NP working at the Burnaby Centre for Mental Health and Addictions. At BC MHA, he focuses on primary care with patients who have complex concurrent disorders. He recently co-authored a case review on cannabinoid hyperemesis syndrome. In working alongside this population, Lukas has become passionate about mental health, substance use, and addiction medicine. He hopes to utilize the education and training experienced through the fellowship to provide the most evidence-based addiction medicine to help those he is fortunate enough to work with. So thank you, Lukas, and I'll pass it over to you.
All right, thanks for the intro, Zach. Thank you very much. Yeah, my name is Lukas Hestvik, and I'm an addiction nurse practitioner fellow. Today, the title of my presentation is Gabapentin, the Potential for Misuse and Mislife. So let's get right into it. So first, I just want to start off with a land acknowledgement. I respectfully acknowledge that I am a humble guest on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh. I have no conflicts of interest to declare. And then I just want to start off by discussing terminology. So some of the terminology used in the research is a little bit out of date. It can be even offensive at times, and some of it is not trauma-informed, and we want to practice in a trauma-informed lens. So if this is noted during the presentation, please realize that was taken from the research articles. It's not meant to be offensive, and it wasn't my terminology used. Some of the terminology that you may hear is things like addicts, drug users, addiction, non-adherence, non-compliant. Some of these are not trauma-informed. So ideally, terminology such as persons who use drugs, substance use disorder, opioid use disorder, misuse, things like that should be used instead. Misuse is what I'll be using during this presentation, and that's to capture the meaning that the medication taken was not taken for the intended medical purposes. And just to note, although many of the research papers that we'll be discussing today mention pregabalin and gabapentin, I'm going to be focusing solely on gabapentin for this presentation. So just an outline to kind of help you track my thought process, so we can go through this together best we can. First, we're going to start the outline with what is gabapentin. We'll do a small amount of pharmacology. We'll discuss what the indications for gabapentin are and what else is prescribed for. So what's prescribed for off-label. We'll go through a side effect profile, and this is really important for later discussions, as we're going to discuss how it has historically been thought to have a relatively safe side effect profile. We're going to kind of break that down further. We'll talk about the history and trend of gabapentin prescribing, and then we'll get into the role it plays in treating neuropathic pain. We're going to touch on its efficacy in treating this common condition, and we're also going to talk about lumbar pain to see how it's used for that. And then we're going to do a deep dive into the literature to discuss the risk for misuse and mortality associated with gabapentin, especially when combined with opioids. And then we'll kind of summarize, have a discussion of what the overall concern is, and then we're going to have a discussion on what we can do as healthcare professionals moving forward with this evidence that we're talking about. So two main objectives today that I wanted to discuss as the potential for misuse and for mortality associated with gabapentin, especially when combined with opioids, and then to consider what we can do moving forward to increase safer prescribing of gabapentin and the consideration of illicit gabapentin use. So I'm hoping at the end of this presentation, we'll have a somewhat better foundation, better understanding and knowledge base of the potential risks associated when gabapentin is prescribed. So let's get into the pharmacology a little bit. Gabapentin is an analog of the primary inhibitory neurotransmitter GABA. So it means it's structure related, but it's different. It doesn't directly stimulate GABA. So it actually has a high affinity for the alpha-2 delta-1 subunits of the calcium channels. This is what inhibits the release of excitatory neurotransmitters in the presynaptic area, and that's by decreasing the calcium influx to the gated channels. So that's kind of a mouthful, but if you look at the red presynapse, you have kind of the green calcium channel there, and then you have the pink, that's the alpha-2 delta-1 subunit, and then the blue kind of half circles are gabapentin pregabalin. So they latch onto the pink subunit of the calcium channel, and that's what stops that kind of influx. So this is the mechanism that's believed to cause the analgesic, anxiolytic, and anti-epileptic profile of the medication. And the theory is that gabapentin interacts with the dopaminergic system, and this is what leads to the potential for dependence and potentially misuse. So it was initially developed in the 1970s in Japan, and it was used at the time as a muscle relaxant and an antispasmodic agent. And then it was later discovered to be an effective treatment for seizure disorders and as an adjunct to other anti-epileptics. And then it later on became FDA approved in 1993. So the on-label indications are for partial seizures and for post-herpetic neuralgia. However, I found it interesting, if you look at the Pfizer drug monograph, they only mention its indication as an adjunct for adults with epilepsy. What they say is who are not satisfactorily controlled by conventional therapy. That's a quote from them. And they actually don't mention post-herpetic neuralgia anywhere on the monograph, and they don't actually mention neuropathic pain of any form on their monograph. So I'm hoping this works out. We'll try this. I want to do an online poll. So if folks are able to go to menti.com on your computers, and if it doesn't work, that's fine, but I want to see if we can make this happen. Go to menti.com, and then you put in the code 5464132. And I'll leave that up for just a couple seconds. I'm hoping this works. And then my question, if you get to the poll, is what have you seen gabapentin prescribed for? So be on-label, off-label, weird label, whatever you've seen. What have you seen it prescribed for? And if you're able to get to the poll, you can put as many answers in as you want. So let's see if we can make this happen. So again, the code for it is 5464132. We're going to try our best. Let's give it a few moments. If this doesn't work, I will just move on, and I'm going to go over some of the off-label things. So let's give it a few more seconds. I was hoping I'd be tech savvy enough for this, but probably not. Nice, we got one. Seizures, correct, you win. Hey, there's more, all right. Chronic neuropathic pain. Okay, I'll leave it at that. Oh, never mind, I was wrong. Okay, perfect, nice. Everything's coming in. So that was what I was hoping for. So you can see alcohol use disorders, sleep, general neuralgia, pain, alcohol withdrawal, opioid sparing analgesia. That's huge. Mood stabilizer, anxiety, neurological in general. It keeps going. That's perfect. GHB withdrawal. Awesome. Okay, thank you everyone. That's great. So hopefully I can go back to my presentation. Okay, so that's perfect. So the reason I did that is I wanted to kind of demonstrate the gabapentin is used for a multitude of things, and we've all seen it used for different things. And that was the purpose of that, so that was great. So some of the off-label uses, according to UpToDate, diabetic neuropathy, alcohol withdrawal, restless leg, migraines, social anxiety, hiccups, fibromyalgia, cough. It goes on and on and on. So what I found very interesting is that the off-label use is actually approximated to be responsible for 83 to 95% of all gabapentin prescribing, as opposed to on-label. And I do want to mention that although these are off-label, some of these indications have more evidence for gabapentin than others. Like we know there's a strong body of evidence for gabapentin for alcohol withdrawal, for relapse prevention, things like that, if you compare it to things like cough and hiccups. So just something to note. So a little bit more of the pharmacology. I want to talk about the bioavailability of gabapentin. So it differs from pregabalin in that its dose is non-linear. It's been shown that for hepatic neuralgia and diabetic neuropathy, doses of greater than 1,800 milligrams didn't actually have a significant clinical benefit. The bioavailability of gabapentin at 900 milligrams is 60%, and it goes down from there. So at 1,200 milligrams, it's just less than 50%, 2,400 milligrams, 30%, 3,600 milligrams, 33%. So just to summarize, at 900 milligrams, it's 60%, and about half at 3,600 milligrams. So I bring this up to ask the question, what are we prescribing gabapentin for, and why are you prescribing the dose that we're prescribing? So I'm going to take a look at these two graphs, and this is from the FDA access data. You can see in the first figure at the top right of your screen that gabapentin 1,800 milligrams and gabapentin 2,400 milligrams actually have the same impact on the mean pain score. It's actually two lines, they're just intersecting and basically the same there. So this was obtained from an RCT that evaluated analgesic effect of the two doses of gabapentin on the intention to treat population. It was a 7-week long study that was double-blinded. So moving on, looking at the graph or the chart at the bottom left of your screen. So this figure is evaluating the results from the previous mentioned study, plus another one that had a very similar protocol, and looked at the amount of responders with an equal to or greater than 50% reduction in pain. And it's similar between all three doses. And if you look closely, you can see that greater than 50% or equal to or greater for gabapentin 3,600 milligram, there was actually less responders than the smaller doses. So I thought that was worth highlighting. This is just as we start to go through the literature now, do a deep dive in the literature on gabapentin. This is just to kind of explain how I want to go through it so you can kind of track my train of thought. There will be a little bit of overlap and going back and forth, but just to kind of help you digest the information we're going to go through. So first, we're going to look at the trajectory of gabapentin prescribing. Then we'll move on to the effectiveness of gabapentin for commonly prescribed conditions. We're going to talk about neuropathic pain and lumbar pain specifically. And then we'll look at potential for gabapentin misuse. And then we're going to go on to the potential for gabapentin adverse outcomes. And those are our objectives for today. So gabapentin prescribing. Gabapentin is not a controlled substance in Canada. The number of prescriptions have been increasing substantially. In the US, prescriptions for gabapentin actually increased from 33 million to 57 million between 2011 and 2015. And in 2016, gabapentin was actually the 10th most commonly prescribed medication in the US. So mechanism is not completely understood, but we know that gabapentin can cause CNS depression, which in turn causes drowsiness, sedation, and potentially respiratory depression. It's because of this CNS depression that when it's used with other CNS depressants, such as opioids and alcohol, for example, they can have an additive CNS depressing effect. And it's been reported actually that the bioavailability of gabapentin is increased by morphine. So recommended daily dose is 900 to 3,600 milligrams per day in up to 4 divided doses. So the common side effects I've touched on a bit are dizziness, drowsiness, fatigue, ataxia, nystagmus, and peripheral edema. So gabapentin, like opioids, is often prescribed for its analgesic effect. And historically, gabapentin has been prescribed with less concern due to its presumed safer side effect profile. So now let's get into the literature and start looking at the gabapentin prescribing trends. So the authors of this article, they noted that the deaths associated with gabapentinoids, so gabapentin, pregabalin, and oxycodone were increasing in England, and they were concerned regarding the potential harms of use and misuse of these medications. So they wanted to evaluate the prescribing patterns of these three drugs in community prescribing and for very high prescribing to determine if there was a public health concern. So this is a retrospective study looking at open source data, looking at the primary care demographics and prescribing, and they were looking between the years 2013 and 2018. So the results were that year over year, the prescribing of gabapentin, pregabalin, and oxycodone have been increasing substantially, but oxycodone to a lesser extent. They also identified there was a trend that these drugs were prescribed more in the lower socioeconomic areas, and that there was a 313% higher rate of gabapentin prescriptions in the most deprived areas compared to the least deprived. So I found that worth noting, and we'll touch on that a little bit later on briefly. So in the 2013-2014 year, there were just under 4 million prescriptions of gabapentin versus 6.72 million in the 2017-2018 year. So the authors went on to suggest that the substantial increase in the gabapentinoids may be related to the increased caution of prescribing opioids, as well as the limited options for treating chronic pain. And this is going to continue to come up during this presentation. So they actually made some suggestions suggesting that a harm reduction approach would be to increase the accessibility of specialist services and non-pharmacological interventions for chronic pain, as well as promoting education for primary care clinicians and the public regarding chronic pain. Sorry, 1 second here. I'll go back, skip one. So this is a graph that's just kind of summarizing that. So you have the chart at the top, the graph at the bottom. So the top image is a graph from the study. Y-axis is looking at the number of prescriptions per year in millions, and the x-axis is years 2013 to 2017. You can see the increase in gabapentin prescriptions substantial, and the oxycodone was to a lesser extent. And then the table at the bottom looks at prescriptions per 1,000 in GP practice. So per 1,000 in 2013, gabapentin at 83.6 compared to 136 in 2017. There we go. Okay, so taking a look at neuropathic pain. So gabapentin for neuropathic pain is one of the more common reasons that it's prescribed, one of the most common actually. So let's take a look at the research looking at how effective gabapentin actually is at treating neuropathic pain. So this Cochrane review ultimately stated that there is moderate quality evidence that gabapentin of doses 1,200 milligrams or more has an important effect on pain in some people with moderate to severe neuropathic pain due to post-herpetic neuralgia or diabetic neuropathy, so two specific neuropathic type pains. And this was a review to assess the analgesic effect and side effects of gabapentin, specifically in the chronic neuropathic pain in adults. It was published in 2017. It was an update from previous reviews about 4 or 5 before. So it's a good body of literature. They were reviewing double-blinded RCTs that compared gabapentin to placebo or other treatment modalities. And they looked at doses between 1,800 and 3,600 milligrams, and they could actually provide pain relief to some patients with post-herpetic neuralgia and diabetic neuropathy. There's only limited evidence for other types of neuropathic pain, though. And the review looked at 50% or greater pain relief, as this can demonstrate more useful outcomes such as quality of life, sleep, mood, functionality. And the review found that approximately 3 to 4 out of 10 patients achieved this level of pain with gabapentin compared to only 1 to 2 out of 10 with placebo. And greater than half of those prescribed gabapentin will actually not have significant pain relief, but may experience the side effects of the medication. So the number needed to treat was for 50% or greater for this type of pain was 6.9. So this is another chart from the Cochrane review, and this was looking specifically at peripheral diabetic neuropathy, and the number needed to treat was 50% or greater, was 6.6. So now let's take a look at gabapentinoids for lumbar pain, which is one of the more disabling health concerns and a very common one that's seen in primary care. So gabapentins are becoming increasingly common for treating lumbar pain. And I found this surprising with or without radicular symptomology. Healthcare professionals often feel like their hands are tied when it comes to treating these chronic pain conditions, just because of what's available for medication. So opioids often are indicated, and we know the side effect profile, we know about the risk of misuse and dependence, and there's substantially increasing publicity on the adverse effects of opioids, especially in lieu of the crisis. If we look at NSAIDs, they're often contraindicated due to other comorbidities. If we look at acetaminophen, it may not be effective, also may be contraindicated. Antidepressants may be trialed, But for all of these medications, there's limited evidence on their long-term efficacy and safety. So in this systematic review, 14 out of 15 comparisons showed that anticonvulsants were not effective in decreasing pain or disability in lumbar pain with or without radicular components. Ultimately, the systematic review and meta-analysis showed that anticonvulsants, gabapentin and pregabalin, are ineffective for lumbar pain with or without radiculopathy. And there was high-level evidence supporting the risk of harms. And they looked at adverse effects again, the most common being somnolence, dizziness, and nausea. So aberrant use or misuse, because I've never figured out if it's aberrant, aberrant, or whatever. So we're going to talk about the misuse of gabapentin, or the potential for misuse. So it is thought of as an opportunistic drug of misuse. This continued to come up in the literature that I was reviewing. It's inexpensive, it's not controlled, and it has increasing rates of on and off label prescribing, which we've seen. It has the potential for misuse, and its ability to potentiate opioids is becoming more and more well known. It seems every year, and that's why I noted in the literature. In the first U.S. assessment of the prevalence of gabapentin misuse, gabapentin had comparable rates of misuse to drugs that already had established misuse potential. Gabapentin was being prescribed or diverted at average daily doses that exceeded the maximum FDA recommendation by threefold, actually. And in another national assessment of medical harm, evaluating gabapentin combined with opioids, approximately a quarter of those with prescriptions for both classes of drugs had at least 3 prescriptions for doses greater than maximum thresholds. This number is 3% for gabapentin prescribed alone and 8% for opioids prescribed alone. We know that there's a recreational market for gabapentin. This started in the early 2000s with a higher propensity with heroin users, and that needs to be highlighted, and we're going to continue talking about that. The reason being is the euphoric and anxiolytic effects, as well as improved sociability, and those were 3 things that continue to come up. It does have reports of producing euphoria, relaxation, and some people are reporting a marijuana-like high. And it was noted that gabapentin is widely used among heroin users. So this study here was conducted because of the increase in gabapentinoids, the misuse of them, and the associated mortality, which actually led the UK to making them Class C controlled drugs as of April 2019. So the UK actually went ahead and did make some changes to how it's prescribed. The authors of this study know that between 2012 and 2015, gabapentin prescriptions in the UK increased from 3.5 to 5.7 million, and that there was a corresponding increase in deaths where gabapentin were on the certificate of death. However, gabapentin and pregabalin, they're not routinely screened for on postmortem talks, so it's hypothesized that the number of deaths related to gabapentin and pregabalin might be significantly underreported. So these authors want to evaluate the prevalence of gabapentin and pregabalin in postmortem talks, as well as the potential underreporting of polysubstance use. So the authors recognized that it wasn't possible to determine the rates in the postmortem cases because they're not routinely screened for. So between January 2016 and December 2017, there's 3,750 coronary cases that underwent routine toxicology screen, plus they added specifically testing for gabapentin and pregabalin. And what it shows that deaths associated with these 2 medications were significantly underreported, potentially by greater than 50%, which I found staggering. So 68 of the 118 gabapentin positive cases didn't mention gabapentin in the case documents, and they would not have actually been tested, which leads to the significant underreporting, and the exact number was underreporting of 57.6%. Gabapentin was positive in 3% of the overall cases, and the most common drugs that it was co-administered with were non-heroin related opioids, such as being morphine, tramadol, methadone. Those are most common, as well as antidepressants. So 6.5% of the heroin users were positive for gabapentin, compared to only 2.8% of non-heroin users. So what that number shows us is that there's a 2.3 times higher prevalence of gabapentin in the heroin users versus non-heroin users. So they conclude that there's significant underreporting and disproportionate misuse by heroin users. and gabapentin is being used with opioids, increasing that risk for respiratory depression. So for this article, the authors went on to suggest that these drugs should be included in routine post-mortem toxicology. They made that suggestion and recommendation, and that prescribers need to be cognizant when prescribing CNS depressants with gabapentin, especially if there is a substance use disorder involved. All right, just 1 second. So here the authors recognize the potential of gabapentin pregabalin misuse, because just like myself going through literature, it continues to come up. They want to estimate the proportion of all pregabalin and gabapentin fatalities related to the misuse in 2010-2011 in Finland. So it was a Finland-based study. What they did was they evaluated the medical legal death cases in Finland between those years with pregabalin and gabapentin in the post-mortem toxicology. Gabapentin was found in just 43 of the cases. The drug misuse was associated with 18.6% of those gabapentin cases, though. And gabapentin toxicity accounted for just under 5% of the gabapentin cases. In these cases, gabapentin was identified as the main substance. In the gabapentin, they said abuser but misuser group, 87.5 of those cases investigated had concomitant use of opioids. So we see that with gabapentin, there's often concomitant use. And there was actually no cases where gabapentin was the only substance. Alcohol or opioids were found in every single gabapentin misuse case. So this was a team of international researchers. They also reviewed online anecdotal reports of pregabalin and gabapentin, which I found a little bit unique and interesting. But they were trying to find out what people were reporting with their use. And the reports showed there was sedative effects as well as dissociative or psychedelic effects. And it's believed that the cause of intoxication and ultimately death from gabapentin is from severe CNS depression with possible respiratory depression, especially when combined with opioids. There's also been some reports of cardiac complications and serotonin syndrome. And these researchers suggested that gabapentin should be classified actually as a benzodiazepine-like drug with considerable abuse potential. That's how they termed it. So we'll take a look more at gabapentin misuse and diversion in the systematic review. So here, the authors, because they recognized that there was this seemingly misguided kind of status quo around gabapentin, that it's not misused or that's used or it's not used for illicit purposes. And because of this, it's liberally prescribed for a multitude of off-label purposes, which we've seen, even though there are increasing reports in literature of its misuse. So they conducted a systematic review, estimating the prevalence of the effects of the causes and risk factors for gabapentin misuse and diversion. So they looked at peer-reviewed papers, they looked at gabapentin misuse, and this was defined, and I appreciate that they defined misuse in this paper, as taking larger doses than prescribed, illicit gabapentin use, or diversion. There were 33 papers, 23 case studies, and 11 epidemiological reports. So what did the results show? Gabapentin misuse in the general population is 1%. This increases, though, to 40 to 65% of those with a prescription, which I found staggering, and 15 to 22% of those with misuse who misuse opioids. They also looked at subjective reports, kind of get that anecdotal experience again. And for those who with opioid use disorder, 40% report using a higher dose of gabapentin than prescribed, and 13% report using gabapentin when it wasn't prescribed at all. So they also wanted to take a look at the motivations behind gabapentin. Why is it being misused? What is the purpose and the reason? So what they were finding out was that recreational use, treating mood and or anxiety symptoms, increasing the effects of other substances, intentional self-harm, unfortunately, for self-treating pain, also using it to manage cravings and withdrawal from other substances, and then substitution for other substances, and then straight up just addiction or dependence to gabapentin. So they tried to find out what the effects were that people were feeling. They reported euphoria similar to opioids, but not as strong when taken alone or when combined with other opioids. I found this very interesting. Some folks would actually snort gabapentin and get a similar high to that of cocaine. There was other reports of sedative effects. So the effects typically were either euphoria, sedation, or dissociation. And although subjects were taking supratherapeutic doses, the effects were typically seen actually in the therapeutic range. So ultimately, what they were discussing is that gabapentin was identified through the systematic review as having a high propensity for misuse. And the motivation for misuse fell into 3 different categories. There was recreational, self-harm, and then self-medicating. And a history of a substance use disorder, especially opioid use disorder, is a big risk factor for illicit use of gabapentin. And it's also it's expensive and easy to get. And some people refer to gabapentin as the cheap man's high because of its ease of access and price. So we're going to talk a little bit about its use in the heroin user population, because so far we've been looking at the literature that recognizes the increased potential for misuse, but I kind of want to focus in here. So in this study, the authors, they were recognizing that gabapentins were prescribed liberally for an assortment of diagnoses. They also recognized that gabapentinoids were being misused to the point of dependence, especially among those who had opioid use disorder. They recognized that there had been recent discussions regarding overprescribing of gabapentin, which actually led the Public Health England and NHS England to provide advice for prescribers back in 2014. So we see there's been steps along the way. And what they recommended at that time, that caution be used when prescribing gabapentin due to the risk for misuse and diversion. They also know the Finland study that we looked at earlier, looking at the toxicology reports, and that there was significant underreporting. The purpose of this specific study was to assess the risk of opioids with concomitant gabapentin pregabalin use. So they reviewed statistics from 2004 to 2015, so a large body of statistics there. And they were looking specifically for mention of opioids and gabapentins. They also conducted interviews with 30 participants who used heroin, and they also conducted a study on mice to evaluate the respiratory effect of pregabalin alone and with opioids. So there's 3 arms of the study, kind of very interesting. And this is one of the few parts of this presentation where we'll touch just on pregabalin, just because that was the research available. So what were the results of the study? So gabapentinoid prescriptions increased by nearly 25% per year. Gabapentin was associated, or gabapentin-associated deaths increased from less than 1 per year to 137 per year in the year of 2015. And about 80% of those deaths also had opioids involved. The increase in deaths had a high relation to the increased number of prescriptions. So what we continue to see is prescriptions go up, number of deaths associated go up. And heroin users stated that pregabalin is easy to get. They also mentioned that heroin and pregabalin increases the heroin effects, but the people using this way, they were actually concerned that it can cause blackouts and increase their risk for overdose. So I found it very interesting that they were aware of this. So the study part in regards to mice, what they noted was that actually low dose of pregabalin might actually reverse opioid tolerance and cause respiratory depression in doses of morphine that were previously not causing this respiratory depression. And at a high dose, pregabalin alone, without opioids, actually was causing respiratory depression in opioid-naive animals, which also had a compound effect with opioids. So I just want to touch quickly on some limitations of the study, though. They did take a pragmatic approach with a smaller sample size with the interview of 30 individuals using heroin. So it can be challenging to generalize it to a larger population. In regards to the study of the respiratory depression in the mice, the researchers, they didn't try to determine the mechanism that caused the respiratory depression. They only determined that it was caused by pregabalin. So they concluded that for heroin users, concomitant use of opioids and gabapentinoids does have the potential for increasing the risk of overdose death. I found it noteworthy that they mentioned overdose death as opposed to just overdose. And this is due to either the reversal of the tolerance to opioids or the synergistic effect of both medications together on respiratory depression. So they know that gabapentinoids aren't actually discussed in the current overdose prevention guidelines for opioid use disorder, or for opioid users, sorry. They mentioned that chronic pain especially neuropathic pain, is very common and very challenging to treat, and there's limitations in the treatment available. So given the findings from this study and others, they recommend that alternatives to gabapentinoids should be offered when treating patients with neuropathic pain and opioid use disorder or general anxiety disorder. So at this point in the presentation, we're starting to get to a point where we're starting to see a lot of redundancy and evidence saturation literature, and I hope that that's coming through. Because that's the point that I'm trying to make. So we're going to take a look at this chart here. I think this sums up everything quite well. So the y-axis, just look at the number of prescriptions, the x-axis in years. So we see that the gabapentin prescriptions significantly increased from 2004 to 2015. Like gabapentin and opioid-associated deaths significantly increased from 2004 to 2015 as well. So in this study, the authors know that there had been an increase in the prescriptions and also its recreational use. Between 2011 and 2015, as we know before, the number of prescriptions increased substantially in the US, but there were a few fatal overdoses of gabapentin reported actually in the literature. And they report of those, the patients didn't typically die. They usually presented with coma, hypotension, respiratory suppression, somnolence, slurred speech. They know that in recent years, gabapentin prescriptions were increasing in the post-mortem medication list, actually. This was a correlation with increasing reports of gabapentin misuse. So the authors, they also know that people who use drugs are using gabapentin for the purpose of intoxication, as well as increasing the effects of their methadone. And I really want to highlight that part. So I thought this was quite substantial, that in 2017, the Virginia General Assembly actually made an emergency enactment clause to their Drug Control Act, and they added gabapentin to the list of medications to legally regulate. So in this study here, the purpose was to determine the incidence of gabapentin-related deaths and to compare to the results of driver's tests for intoxication to have a greater understanding of the therapeutic and possibly fatal ranges of it. So they did a retrospective study reviewing 104 postmortem cases that were gabapentin positive, and then 53 non-fatal MVA cases of suspected impairment. And then again, routine toxicology doesn't always include gabapentin, so these cases were included just because those were the ones where it was suspected. So what did the results show? 47% of the postmortem cases, gabapentin was directly implicated in death and contribute to the death in an additional 11 cases. So the authors know that one of the limitations, which we should discuss, is that gabapentin testing is not routinely done. We've mentioned that quite a few times. So this is showing again that there's underreporting. So there was just over 75% of the cases in which gabapentin was actually deemed causative, and 77% also had at least one opioid as well. So we're seeing that again. Gabapentin is being the cause when combined with opioids. Just over 90% were prescribed the gabapentin, and 84% had a known substance use history. So the majority of gabapentin-related deaths also were positive for at least one opioid. We saw that, and 50% of these, 54% of these, didn't actually have a prescription for at least one of the opioids. So they conclude that gabapentin misuse is significantly higher in those with a substance misuse history. I want to highlight that. They also suggest that concomitant gabapentin opioid use has a significant risk for gabapentin-related death. And the authors suggest that prescribers need to be more cognizant that gabapentin does carry the risk for misuse, especially for folks who have a history of medication misuse. And just because it's not an opioid, it's not necessarily make it a safer alternative in that population. So practitioners should also follow their patients more closely if they're prescribing for chronic pain as an opioid alternative, especially if there's that history of misuse. Those were their ultimate conclusions for that study. So this is actually an Ontario-based study here. And the authors, they discussed the prescription opioid use is highly associated with opioid-related death, which we know. The statistics show that 1 in every 550 chronic opioid users actually dies within about 2.5 years of their first opioid prescription. And then they mentioned again that although gabapentin has historically been thought of as a safe medication or safer medication, it's been associated with respiratory suppression when taken alone, and especially when combined with other drugs. So these authors know that prior to this article, there hadn't been any studies that they knew about evaluating whether gabapentin and opioids taken together was associated in an increase in opioid-related deaths. So they wanted to evaluate if concomitant use of these drugs was associated with an increase in opioid-related deaths. And they collected data actually from 1997 to 2013. So a large body of data there. So cases were defined as opioid users who died from opioid-related deaths, and then they had 4 controls who also used opioids. They looked at age, sex, year of birth, history of CKD. And the primary exposure was concomitant gabapentin administration within the past 120 days from the index date. And there was also a secondary index looking at gabapentin doses. So they looked at low dose being up to 900, moderate 900 to 1800, and then high dose was 1800 milligrams and above. So what did the results show? Just over 12% of cases and 6.8% of controls had a prescription of gabapentin in the last 120 days. And there was about a 50% increase in opioid-related death with concomitant use compared to opioids alone. And I thought that was very significant. Moderate and high gabapentin doses were associated with a 60% increase in opioid-related death compared to no concomitant use. Just a few of the limitations real quick for this sample study is that it was generally limited to a lower socioeconomic class, as well as being limited to patients receiving opioids for non-cancer pain. So they concluded that co-prescription of both drugs was associated with a significant increase in opioid-related death when compared to opioids alone. And they recommend that practitioners should reconsider actually co-prescribing these medications together. And if it is necessary, if you have to prescribe it together, that they should have closer monitoring, and we should consider dose adjustments. So just in lieu of time, I'm just going to bypass this article a little bit. I want to make sure it's time for questions at the end, getting a little bit close. But the takeaway from this was just that the overuse of gabapentin and concomitant use with opioids increase the risk for harm and requiring hospital services for respiratory depression. That's what they were looking at, is if people are having to use ER services and inpatient services more. So you can always get these slides in the slide deck after if you like. So thanks for bearing with me through doing that deep dive in the literature. I was hoping that you'd see that evidence saturation come through. So I want to take a look here at something that the FDA put out. So on December 12, 2019, the FDA actually put out a warning that gabapentinoids could cause serious breathing issues for those with respiratory risk factors. Those respiratory risk factors being CNS depressants, COPD, elderly, and use of opioids, which is a CNS depressant. So this was actually what brought this issue to light for me and had me look into this further back when this came out. So they identified in their research that gabapentin prescribing had increased for medical concerns, and also that there had been an increase in misuse and abuse, which is how they termed it. And this comes up in the literature a lot. So when combined with CNS depressants, it can lead to respiratory depression. The FDA stated that. CNS depressants, they looked at opioids, anxiolytics, antidepressants, and antihistamines. And they mentioned that there's less risk when gabapentinoids are taken alone or in healthy individuals, which makes sense. So what is the FDA approving, or sorry, what is the FDA doing now that they noted this? So they're actually requiring added info to be applied to the prescribing packages of gabapentinoids. And they're mandating that manufacturers start clinical trials to further assess the risk for misuse, especially when combined with opioids. Because as they say, this is a quote from them, misuse and abuse of these products together is increasing, and co-use may increase the risk for respiratory depression. Sorry, went too far. One second here. Nope. There we go. Sorry. So what is the cause for concern? So kind of, I want to summarize everything together, make it a little more tangible, user-friendly. So after looking at the recent literature and the studies that evaluate the potential for misuse and potential harms of gabapentin, especially when taking concomitant opioids, let's review what we found out. So gabapentin is historically known for having a relatively safer side effect profile compared to opioids, as then thought of as an opioid substitute. This seems to be what may have led to the significant increase in prescriptions. I call it the back pocket medication. You always have gabapentin in your back pocket, or that's what's thought of. So gabapentin use, as well as related harms such as morbidity and mortality, have been increasing. And those of lower socioeconomic status may be at higher risk for adverse effects from dependence-forming medications. This is actually evidenced by alcohol consumption being more likely or to be greater in the middle and upper class, yet alcohol-related complications are disproportionately greater in the lower class. So that's kind of an example of that there. And this is also the demographic of patients who are more likely to be prescribed gabapentin as well. It's not a controlled substance, and it's not routinely screened for in postmortem toxicology. It has to specifically be suspected and then requested. So there's potential that there is more overdose than we realize, and that overdose is being underreported. It has the potential for misuse. We've seen that over and over from the articles, and this increases in patients who have a history of medication misuse. It is used for illicit purposes, intoxication, as well as to potentiate the effects of methadone, heroin, and other opioids. I think we need to be aware of that. And it also has been used to self-treat pain and mental health concerns, and unfortunately, it's also been used for self-harm. So when co-administered with opioids, it has the risk for overdose death. And I think that's a big takeaway from this. So gabapentin can increase the opioid effects as well as the risk of misusing either family of medications, and the gabapentin misuse is frequently seen among those who misuse opioids. So when it's co-administered with opioids, there is the risk for respiratory depression and death. There's actually a fourfold increase in the risk for respiratory depression. And doses of greater than 900 milligrams can cause a 60% increase in the odds of opioid-related mortality relative to misuse of opioids alone. That was a stat that I found quite staggering. So what can we do? What should we do as healthcare providers and practitioners? What can we do with this information? So I'm going to go through a few things. Some of these are just questions. Some I think maybe I have an answer to, or I'm thinking about it more. Some of these questions I don't have the answer to as well, but I just propose to all of us to consider moving forward as healthcare professionals. So one thing is, much like antibiotic stewardship, which has attracted a lot of public attention and awareness, or the public awareness regarding the opioid crisis and increasing awareness on prescribing these medications, we can increase practitioner public education and awareness regarding the potential harms of gabapentinoids. So I was just trying to think of what's one simple thing we could do. So we see lots of posters in waiting rooms, for example, regarding alcohol use in pregnancy, harm reduction strategies for opioids, the harms of cigarettes, the harms of obesity, so on and so forth. Because of simple education, things like these posters, a lot of people have a basic foundational knowledge of these health topics. So something simple like having posters and advertisements in the healthcare system about the risk for harms of gabapentin could start the conversation and also just start knowledge translation among ourselves. I think there should also be more education for pharmacists, as they're an incredible resource that many patients look to get those safety checks before they get their medications. They're kind of the last stop before getting their medication, and often those words stick with them the most. So we need to also consider policies and practices given the weight of the evidence. The FDA is already making some changes, so they stated that new warnings will be required regarding the risk for respiratory depression to the gabapentin prescriptions. I think this is a good start, and I hope that they follow through on doing more clinical trials as well. So some of the questions I propose is, should gabapentin be a controlled substance like it is in some of the states and in the UK? We see changes have been made all the way back to 2014. Should we be screening patients for potential misuse and diversion? And should it be screened for more routinely on postmortem toxicology screens so we are having a better idea of what the actual overdose rates are? And if we're screening folks for misuse of gabapentin, what would this look like, as we don't currently have guidelines for this? Should we have more access to UDS testing for gabapentinoids? Should we adapt the DSM-5 criteria for other misuse disorders to see if there is some indication that there is misuse? We could do a quick expert using the single question screen, just how many times in the past year have you used gabapentin for non-medical purposes? So one thing I ask, and I don't have the answer to this, but should gabapentin misuse disorder be considered as a DSM-5 diagnosis? Should we be extra cautious in co-prescribing gabapentin with opioids, benzodiazepines, Z drugs, other CNS depressants, as the evidence shows that there is increased risk for respiratory depression? And some of the articles directly recommend that gabapentinoids be reclassified similar to benzos and Z drugs. And I think this should be strongly considered. Should we be extra cautious in prescribing gabapentin in patients with a history of opioid use disorder? I think it should be strongly considered. And then in regards to prescribing, should we be prescribing higher than 1,800 milligrams? Should we reconsider what we prescribe it for? Does the evidence really show that doses greater than 1,800 milligrams has an improved effect on analgesia and quality of life indicators, or is it only increasing the risk for harm? And then I think we can consider deprescribing gabapentin for some folks. So after looking at some of the research today, think about patients you've seen in your practice, in the community or otherwise, can you think of patients that may not have had an important medical benefit from gabapentin and may have just been at risk for the harms associated? I think it's worth discussing medication trials when starting gabapentin. So if there isn't a measurable objective improvement in analgesia, quality of life, functionality, things of that nature after a certain time, then considering discontinuing it. You could consider at least reducing the dose and making sure if they have any sort of impaired renal function that their dose is adjusted for that, they're not above the maximum suggested dose. It was mentioned that gabapentin isn't mentioned in overdose guidelines. I think this is an area that could be addressed in the future. I think people are looking at overdose guidelines quite a bit. I think this would really hit home. Ultimately, I think we need more evidence and research to investigate this, and also investigate pregabalin, as a lot of the articles spoke to that as well. I think we need to have more research to look at the exact mechanisms causing the harm. I think that's very important. In the one study looking at the respiratory depression in mice, they didn't actually evaluate the mechanism of harm. They just noted that was due to pregabalin. So I think more studies looking at topics such as what's causing the respiratory depression. And I think we should have some studies looking at prescribers' knowledge of these issues, because maybe prescribers and healthcare practitioners aren't aware, and then we need more general education, or maybe they are aware, and then we need to find out why there is still so much liberal prescribing, if we think it's of concern. And then there's the topic of chronic pain and the challenges that we face when treating chronic pain. And just like one of the articles said, they suggest that we need more research and funding into chronic pain management and treatment modalities, and having different resources available for prescribers to offer for patients. So I think there also needs to be more research on the treatment options for those who have concomitant opioid use disorder, as well as gabapentin misuse, because this is a population that is seriously harmed and affected by this. So these are questions I don't have the answers to necessarily, but I think they should be considered given the evidence for potential harm. And I hope after the presentation today that everyone has a bit better understanding of that. And thanks for bearing with me. Thanks for seeing through the presentation, and I'm open to any questions. So thank you very much, everyone.
Thanks very much, Lucas. You did it. We were wondering if you'd fit it under the wire, but well done. So let's pull up the questions here.
Yeah, I don't think I can see any of them. So
okay. So yeah, so this is your opportunity to pose any questions for Lucas. Certainly in the past, it's with these the virtual format, I know some folks have taken away the content to reflect and have forwarded questions to us after the fact, which is fine. So if that's the case for you, certainly forward to Adrina, who can forward it to Lukas for his comment. And yeah.
I probably answered all the questions, I figured.
You probably nailed it the first time. So so there we go. Perfect. Perfect score.
Nice. I like it. Any questions from you, Zach?
No, I mean, I think that you've done a good job in telling the story of the research. I guess if you had a magic wand to anoint which areas should have a study, and what study would you do, and how would you do it?
Yeah, I think to find out the most information, I would like to know what is the knowledge base of healthcare professionals in regards to this. That was one of my last points. Are people aware of it? We can find out, no, people aren't aware of it, and then we know we need to educate. And then if people are aware of it, then what's happening? Why is prescribing so high? Is it because they're finding in their clinic that it is effective and it's different than what you're seeing in research? Or is it because, and I think a big thing is chronic pain. I think a lot of prescribers feel like their hands are tied. It's super challenging to treat chronic pain, chronic neuropathic pain. Like I said, a lot of the treatment modalities, it's a multimodal approach, but you need a lot of things like pharmacology wise, don't have a lot of research behind the efficacy. And you're weighing the risks and benefits, but you want to try. And a lot of things for chronic pain, like for example, fibromyalgia, is exercise, not so much medications. But do we have funding and resources available to refer patients to these non-pharmacological interventions? That also can be more challenging than just taking a medication and also getting that motivation for it. But we've seen all the research CBT for pain, but do patients have the time, resources, money, motivation to do it? So I think having more funding and research into chronic pain, which is obviously easier said than done. I get that. I get the realities of it. Is somewhere to start as well.
No, those are good points. And yeah, I mean, I think you may be right that in the absence of some of the other best practice resources for chronic pain, we're left with this kind of easy, seemingly innocuous, not that hazardous intervention compared to other things. But
Yeah.
It would be good to study that and see what our colleagues feel about gabapentin or are aware with some of these potential risks.
Yeah, because that's like I mentioned, that's the status quo, that gabapentin is seen as a safer opioid alternative. And I'm not making any claim that it isn't. I'm not saying that one way or another. But I was just quite surprised as I read through more and more of the research that it seemed like this is something that has been discussed in literature for a lot longer than I was aware of, that there is the misuse. And when taken with opioids, the risk for overdose death is substantially higher.
Gotcha.
Yeah.
Okay. Well, let's. We're 1 minute to one, so at the risk of going over, I won't ask any more questions of mine. And I see nothing else has popped up, so so we'll wrap it up there. Thanks to all the attendees who took the time to come. This has been recorded and will be available for posterity if you want to review again, or if you think some of your colleagues might benefit from it and might want to watch. And of course, any questions, shoot them our way. So thank you very much, Lukas.
Yeah.
And
thanks, Zach. Thank you, everyone.
You bet.
All right. See you.